Uh, Dr. Agrawal, good evening, sir. Good evening, ladies and gentlemen. Just waiting for Dr. Samir Agrawal to join us. Welcoming you to a webinar on the subject of procalcitonin, revolutionizing sepsis diagnosis and clinical precision. Dr. Agrawal, good evening. Can I request you to have switch on your audio and video, sir? Good evening, doctor.
Hello, Mr. Majan. Hi.
I think we've got about 83 people joined in. That's a good number for a webinar on a Friday evening. Well, it's my pleasure to welcome you all to this insightful webinar on procalcitonin, a critical biomarker that has revolutionized the field of diagnostic medicine. So whether you're a clinician, a researcher, or a healthcare professional, the importance of accurate and timely diagnosis in managing infections and sepsis cannot be overstated. So today's session, we will do a deep dive into this world of PCT and its applications in medical diagnostics, because it has emerged as a reliable marker today for bacterial infection, and in fact, differentiating between bacterial from viral infections, monitoring sepsis, and even guiding antimicrobial therapy. So uh, the webinar is not just about understanding the science, but also about empowering healthcare professionals to integrate PCT testing into their practice effectively. So we encourage you to participate actively, ask questions in the Q&A box, and I will request Dr. Agrawal to answer them at the end of the session. And please share your perspective, if any, so that we can embark on this learning journey together. So, Dr. Agrawal, over to you, sir.
Thank you, Arjun. Thank you so much. At the outset, I would like to thank JMitra for organizing this great seminar because once we impart knowledge and we gain knowledge, it's a learning curve for everyone, and we are learning all the time. So, starting with the webinar, uh, procalcitonin is a very close topic, a very uh, uh, interesting topic as well as a challenging topic. My first brush with procalcitonin was way back in 2009 when I was handed over a project uh, at Lilavati Hospital to standardize the procalcitonin test. And there was one more molecule there that we were working on. So it is a not a very recent marker, but in sepsis it has grown leaps and bounds. So procalcitonin it has revolutionized sepsis diagnosis, and it has a remarkable clinical precision. So we will talk about the I'll try to take you through the journey, how it was made, and very uh, basic outline, not getting into much of the biology and much of the molecular part of it. But so we'll have an insight into the biomarker utilization in sepsis management. Okay, so the first commercially available PCT assay was the Brahms PCT. It was manufactured, discovered by a group of scientists in France, but then this company was taken over by Thermo. They did this on a luminometer, and later on they did it on on an automated instrument called Crypter. So several diagnostic companies have partnered with Brahms to develop this PCT assay on their individual platforms. Now there are various methods. They are based on ELISA and then Clear, and again they are available on CMIA technology. Then rapid cards are also available. So what is procalcitonin? It's a precursor protein to calcitonin, mainly produced in the thyroid gland in this by the C cells, C follicular cells. Under normal conditions, it is present in small quantities, but in presence of bacterial infection, there is a significant rise. That's why it is a useful marker for sepsis. Now, why is it important in sepsis diagnosis? Obviously, sepsis is a life-threatening organ disease, and there is a massive organ dysfunction which is caused by various infections. Early detection and timely treatment has a major role in patient outcomes. It is critical. Procalcitonin has emerged as a key biomarker to distinguish between bacterial and viral infections, other causes of inflammation. So, for therapy purpose, for diagnosis, for therapeutic usage, bacteria versus viral, we need to figure out which uh, or fungus or other organisms which are causing septicemia. So, as if we compare procalcitonin with other biomarkers like CRP and WBC and other biomarkers, CRP is non-specific, can be elevated in many inflammatory conditions as well as infections. WBC has a diurnal variation. A lot of people, they come back saying in morning CBC, the WBC was 4,000. Now why it is 6,000? So there's a diurnal variation. Please note WBC has a diurnal variation. Okay, can be altered by various factors which are non-specific as well, and they can change because of drugs. There are various factors. Procalcitonin is less affected by inflammatory conditions like viral fevers or infections or trauma or other autoimmune inflammatory disorders. Now, PCT is definitely higher. It has a higher sensitivity. It is it has a faster response also. PCT rises within hours of bacterial infection. Within 2 to 4 hours, it starts increasing. There's a whole mechanism. I have not put that much into detail, but I will look into it further. So, clinical decision making is the key word here, aids in distinguishing bacterial infection from other causes of inflammation. So, this is a table that I pulled out from somewhere, which is just to show that the advantages and disadvantages. Obviously, WBC is inexpensive, simple, but it can rise in any sort of inflammation. Same goes for C-reactive protein, but and also it has a slow induction peak at 24 hours. So and therefore it cannot be used for severity of disease. Then lactate is more for in advanced sepsis when there is a decreased perfusion, blood perfusion. So then the lactate gets released in the blood, but it has a very poor specificity for bacterial infection. PCT is the most specific and specific for bacteria. It has a short half-life and it can predict the severity of illness as well as antibiotic use and the guidance of antibiotic, when to use and when not to use. But obviously it needs to be run on an instrument in the lab, slightly more expensive than WBC, CRP, and lactate. And with so many assays coming up, so many companies making PCT, the cost of PCT has come down dramatically. So, in short, the pathophysiology of procalcitonin, whenever there is a bacterial infection, pro-inflammatory cytokines like interleukin 1, 6, and TNF alpha, they are released. And these are released from various tissues, primarily the liver. So, in response to LPS, that is lipopolysaccharides, the body increases procalcitonin production, which LPS in response to bacterial toxins, LPS gets increased. So PCT levels correlate with severity of infection, and it can be monitored during treatment. This is a diagrammatic representation. Courtesy JMitra provided this slide. So during bacterial infection, there is release of interleukin 1 and TNF alpha from the most of the cells of the body, especially the liver, and then that gets released in the bloodstream. So CT-mRNA gets CT is calcitonin. So in the adipocytes, fat cells, there is a upregulation of the genes, and then there is production of CT-mRNA, and then CT-mRNA produces procalcitonin. That is the protein. So LPS, interleukin 1 beta, TNF alpha, they stimulate production of procalcitonin, and consequently it gets secreted in the serum, in the blood. But when there is a viral infection, there is augmentation of interferon gamma. Interferon gamma, the mechanism is separate, and that's why in viral infections there is only release of calcitonin and not procalcitonin. So that's how it becomes specific in bacterial infection. So role of procalcitonin in sepsis diagnosis. Procalcitonin uh, is a diagnostic tool to confirm bacterial infection. The cutoffs are if it is more than zero point 0.5, then it is strongly suggestive of bacterial infection. And then higher levels, up to 1, 2, above 5, and above 10, they relate with severity of the disease. And uh, SIRS can occur without infection also. So that is also something to look into. So it helps differentiate between SIRS caused by infection versus non-infectious causes like trauma. So systemic inflammatory response syndrome can occur in various other conditions like trauma, burns, or surgery. So PCT can help. Is it a bacterial SIRS or it is non-bacterial SIRS? Again, a diagrammatic representation showing different levels of procalcitonin, then recommended management, then and at what time PCT can be used. So if it is less than zero point 0.1, then no antibiotics are required. 0.25 to zero point 0.5, start the antibiotics and continue antibiotics, and then we look at the subsequent PCT levels at day 3, 5, and 7. And more than zero point 0.5, definitely we need to start antibiotics and then again evaluate. So it has therapeutic importance, it is useful for decision making, and it is for monitoring. So that is how good a PCT is in sepsis. And as we were discussing with Ms. Mahajan, I was discussing, so antibiotic stewardship, again, PCT has an important role now in reducing overuse of antibiotics, because there is a huge antibiotic resistance that is developing in our country. We are a kind of superbug nation. We have to reduce the overuse of antibiotics. So procalcitonin can is definitely being used now to guide the antibiotic therapy. Monitoring sepsis progression, a fall in PCT levels typically correlates with clinical improvement. So we see the outcomes also. Once you identify infection, you treat the infection, then you can monitor the outcome also. So rising PCT obviously indicates a worsening on infection. Fall in PCT is correlates with clinical improvement. So this is how it is. PCT rises within 3 to 6 hours after a bacterial infection, peaks in 12 to 24 hours, and once the antibiotic is given, then it starts falling. The half-life is short, and approximately within 24 hours, it comes to almost baseline. If there is an inadequate treatment, it will continue to remain stable or rise in some cases. So it is useful in patients in ICU, because in ICU there is a lot of critically ill patients who may turn up in sepsis. It aids in identifying bacterial infections and guiding antibiotic therapy. In neonates and pediatrics, it is highly sensitive for bacterial infections. In neonates and pediatric population, post-surgical, if we need to find out what is the cause of inflammation, is it bacterial, it is non-bacterial, again, PCT is the choice of test. So, and specific, if we talk about specific infections, respiratory infection, UTI, abdominal infections, bloodstream, any, so PCT is very good for identifying bacteremia, uh, and in patients with central lines as well, or in suspected septic shock. So, as we had discussed, it helps in guiding antibiotic duration when the PCT rises or falls, we can figure out which antibiotic to use and how for the duration of the antibiotic use. And it has impact on resistance. Obviously, if PCT is normal, there is some sort of inflammation. Is it viral? It is fungal, or is it because of any autoimmune disease? So this is the utility of PCT. It can prevent resistance. Now, obviously, as in no test is perfect, there can be some problems with or some limitations in every test. So PCT may be elevated in certain viral infections, which is though rare, but it is documented for certain viral infections, probably post-transplant patients. Then in certain conditions, there is a transient increase in PCT, but in the if you look at it serially, then the PCT levels come down. Now, it may not be able to differentiate sometimes in the respiratory infections also. But if we did a lot of PCT during the COVID, but if there was COVID which was not infected because of secondary infections, PCT was always normal. But if there was a subsequent secondary infection, then PCT would rise. So sometimes it's in the milieu, in the background of the disease. We really don't know today what the patient has in the blood or in the respiratory infection. So the clinical guidelines and recommendations of European guidelines for clinical microbiology, PCT is recommended for diagnosing bacterial infections. Then American College of Chest Physicians also recommend PCT as the biomarker for monitoring and response to therapy. Now, the future direction, again, PCT in sepsis subtypes, further research would be for subtypes of sepsis, combining biomarkers. There was a study that we were talking about combining PCT with IL-6 during COVID as well. And point of care testing, again, a lot of point of care PCT assays are being made for rapid clinical decision making. Now, this is in conclusion that Procalcitonin is a game changer in sepsis diagnosis and management, and it is the cornerstone in precision medicine for sepsis management. Thank you.
Thank you very much, Dr. Agrawal. Uh, Sir, you've covered PCT and sepsis, and I wanted to understand if you can share with us, given your experience during COVID, any case that you had, any specifically interesting case that you had where PCT as for its diagnostic accuracy, because it was able to differentiate bacteria from viral infections. How has this change happened in the, a case where you could probably talk about the old medical practitioners and how they approached PCT and their, how have they changed over to PCT? Something which defines the turning point from the old system to the new system. Because like you said, PCT is not a very old marker.
Yeah, so if you look at CRP, okay, everybody writes CRP. That's the first test, WBC, sorry, CBC, and then CRP and ESR. Okay. Whenever anybody comes with fever or suspected infection, That is the first test people write. Now, the thing is with CRP, okay, so there was a case during COVID. So obviously everything was treated as COVID, but there were certain infections which were lurking, behind the curtain of COVID. So there was a quick case, some I think 60-year-old lady with a difficulty in breathing, and then they did an X-ray and then subsequently CT also, which shows patches. So COVID test was done. It came out to be non-conclusive. Repeat test was done, again non-conclusive. So then with those patches which were similar to on radiology, classical at that time it seemed like COVID. But then CRP was done, CRP was high. Some apparently D dimer was also slightly high. So now there was a confusion when CRP is high, IL-6 is also high. But then why the COVID is negative? That is the mindset that people have. Okay, that maybe the lab is not doing a right job. Let's
Correct.
repeat the test again. Obviously, ferritin will be also high because it's an inflammatory marker. Now
Primitive.
then we suggested why not go and do PCT. Okay. So did PCT, then we asked them, PCT came out to be 2.2 or 2.3. Then we told them just look at the X-ray, send the culture. Okay, let's do the culture. And so the patient was diabetic and had Klebsiella pneumoniae. It was simple diagnosis. But because you just don't order the right test at the right time, so obviously the diagnosis gets missed.
Yeah, because I
That's
think
how.
ECT makes
Yeah.
it's a game changer, especially in sepsis and bacterial infection diagnosis.
Absolutely.
But
And one
yeah,
more case I would sorry, okay, I'll just
oh,
a
please.
very interesting case, okay, very. So a friend of mine, he underwent cholecystectomy, all right, and he was at the verge of having a gangrenous cholecystectomy, cholecystitis.
Oh,
So it was almost a burst abdomen and all that. So he got that done, and then after 1 month I visited him. He was like, okay, I somehow, but he was having low grade fever in the evening, and he was not. He was losing weight, and it was not diagnosed. So I told him, okay, let's do a couple of tests. So we did. I told him, okay, let's do CBC, and then let's see where it goes. So it showed normal CBC, not a lot of increased counts. Then CRP came high. Okay, and then I said, now CRP is done. Is it viral? It can most likely with the history it may not be viral. Mostly it is sepsis or bacterial sepsis probably. Then how to confirm it? So we his samples were taken, and uh, cultures all came negative.
okay.
Then I said, let's do PCT. Okay, so PCT came out to be normal.
Hmm.
Then CRP gets increased in fungus also, fungal infections.
Correct.
Okay, then beta D glucan was done another. So he basically had a fungal septicemia post surgery. So that is the relevance of PCT. It can exclude a disease. It can confirm a diagnosis.
It's
So
pretty much
that's how good is PCT.
it's almost like the Sherlock Holmes of medical diagnosis, I would say.
Right.
But is it necessary that when CRP rises, PCT will also rise? Is it somewhere linked? Are these two linked somewhere?
Not really. If there's no bacterial infection, because the pathophysiology is quite different.
Okay.
So that's why CRP is not specific. It is sensitive. It increases in inflammation because of virus, fungus, bacteria, autoimmune diseases. So we don't know really what is the cause of inflammation with CRP.
As you mentioned at the very beginning of your presentation, sir, Brahms PCT was the first around town, right?
Right.
And there is the non-Brahms PCT. So, is
Right.
there a difference in terms of diagnostic significance with respect to Brahms PCT and non-Brahms PCT?
No, I don't think so. They were the pioneers. They were the inventors of PCT. They discovered PCT, I
Correct.
think. Yeah.
So, there's no real
But
difference, right? Eventually.
there's no real difference. Now in the real world, when we look at it and we do testing on PCT on various platforms, and various companies are making those kits. So there's no difference. I don't think so. There's any
And
difference.
in during COVID, if you remember, PCT had picked up really big time during COVID, and it was coming really high, sometimes more than 20 nanograms per ml. Any particular reason why this was happening?
Yeah, so PCT can be falsely high in patients who have kidney disease
Okay,
because the excretion of procalcitonin is via urine. Okay, so if a patient has high creatinine or any form of compromised kidney disease, then their PCT will be falsely high.
okay.
Yeah.
Sir, do you think PCT, apart from sepsis and bacterial infection, is you think it has any lesser discussed applications like oncology or autoimmune diseases? Do you think do you foresee any applications evolving in the future, with regard to PCT in these diseases?
Um, See, I think my last slide, which we talked about the future, the research in PCT, it can be a combination, probably with a certain bioassay markers in the future. Probably
Okay.
TNF alpha and interleukin 1, 6, and maybe there are other cytokines also. They they could be used together to uh, give that answer
Okay.
because pathophysiology is very specific of
Very
PCTs.
specific
It's just that,
pathophysiology, of course. So
yeah, yeah.
that's why but like, like we always say, vitamin D uh,
Hmm.
is not a test that is causative for many things, but it is indicative of a lot of things. So PCT also might find its applications down the line,
Could
given,
be,
yeah.
yeah,
Uh,
could be.
my last question, and thank you for being so accommodating on this, is around stewardship and antimicrobial resistance. If you can give us a small share with the audience here today and on why it is important, because they've all heard the term, but not everyone has registered the importance of antimicrobial stewardship. So you could probably enlighten them a little bit more on that. It would be very helpful, sir.
So we read. It's a fact. Okay, now the superbugs are there. There's a lot of resistance. See, old school kind of practice of medicine that has been there in our country. Whenever a patient turns up or a child turns up with fever, cough, cold, diarrhea, first thing is antibiotic is prescribed, and a higher generation of antibiotics are also prescribed without even testing. So empirical treatment may not be now more relevant. It should not be rather done without investigating the cause, because now the accessibility of the lab and good lab work is there. It's affordable, it's reliable, it's accessible. So if we don't have that workup, uh, so what is happening is if indiscriminate use of antibiotics, it is going to definitely increase the resistance for common drugs which were used. Even cotrimoxazole is a very cheap drug. You can get it for 10 rupees. I think, I don't know, maybe 4 or 5 tablets. So that even works for urine infections. So unless you don't test it, how will you know what is working and what is not working? So likewise, if there is indiscriminate use of antibiotics, the bacteria, they develop resistance, and they are going to develop resistance very fast. That is the case with a lot of drugs like meropenem and these class of drugs. Fluoroquinolones also are, now we are finding a lot of resistance, and there are certain bacteria which for chronically ill patients, they are just there, so they don't require any treatment. So again, if we there is a growth which is coming, and patient may not be febrile or maybe slightly febrile, if you do a PCT and there is no sepsis, there is no increase, so you can withhold antibiotics. Unnecessarily giving antibiotics, obviously they cost money and they give rise to future resistance. So we may not have many drugs left to treat uh, severe infections. So mortality is increasing in the ICUs because of this indiscriminate use of antibiotics causing massive resistance to a lot of the drugs. So that is the reason why PCT can be useful in preventing drug resistance.
Thank you very much, doctor. Thank you very much, sir, for joining us today and enlightening our entire audience on the subject of procalcitonin and its usage in various fields of medical diagnosis. Appreciate the time and effort. And thank you, ladies and gentlemen, for joining us with the JMitra Scientific Webinar on 27th of November 24. Please join us tomorrow at 4 p.m. for our discussion with Dr. Khandelwal from Jabalpur, I believe. In Jabalpur, he will be talking about malaria diagnosis. Thank you very much. Thank you, doctor. Thank you, Govind, and thank you, everybody. Have a good day. Jai Hind.
Thank you.